And I'd like to set up for you the idea. I describe today's medical system as a financial system. It is a financing system. The care just follows. Patients come to doctors' offices because that's how that's how I used to get paid. That's how most doctors get paid. Not always because they need to. In fact, if you talk to Blue Cross, I asked them, so why do you pay $19.95 for a visit? How stupid is that? And they said, well, that's because most patients will go see a doctor 2 times for a problem. I said, 2 times? Sprained ankle? They go, oh, yes. I said, I'm not sure which came first, the cart or the horse. Did the patient go twice, or did you make them come back because the value, the reimbursement from the first visit was so small that you actually had to see the patient or send them to your nurse practitioner the second visit in order to make a living? So patients spend a lot of time on freeways, they spend a lot of time in our waiting rooms, and it's all about getting paid. It's not about care. My model, our model, is about care. That's all we deliver. If the patient needs to come in, sure, I've got plenty of time. I will make time. But there is absolutely no reason, if Mrs. Smith's cold is getting better, she's breathing fine, yada, 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 you go through the question and answer list, why should she have to go back so you can stick a stethoscope on her chest and charge her $50? I mean, really, doesn't that discredit what we're doing? Isn't the goal to give that patient a productive day? And wouldn't they be better off at work or doing whatever they want to do than sitting in our waiting rooms? And I will tell you that before I converted my practice, and for those of you who want to know when that telltale day came, it was when I was scheduling patients to come in at midnight, because that was my first available. And patients waited 4 hours on average in my waiting room. That's disgusting, and it's disrespectful. And I said, I can't do this anymore. It wasn't about the money, ever. I needed to be a doctor. And now I'm a doctor, and I'm happy. We call ourselves the happy docs. There are a zillion practice designs, and as I said, and I will help you with any of this, just like Catherine said, I am available, my organization is available. In fact, I'll give a plug. We're having our conference in Phoenix and on February 20th, and another one in San Francisco on April 24th. We're all about helping you make that transition, networking, working with your colleagues. In fact, we've built a local chapter in Orange County. We've got, what worse economy is there than Michigan? Nowhere. And yet our doctors in Michigan want to build a local chapter. There are enough physicians there that they actually want to get together and build a chapter in the worst economy in the country. What does that tell you? This works. This works. In addition to that, how many of you are specialists? Fabulous. What we're building around this primary care structure is what we call a private care network, where we help support our specialists. You know, I have to tell you that the CMS ruling to take away your consult fees kills me. It's disgusting. And trust me, I'm very politically involved in trying to get that back. That said, the answer is, of course, divorcing yourself from all those systems. But in the meantime, I need you. My patients need you. We need each other. If we don't have networks of the best doctors to take care of our patients, we have lost the profession. So we have to help each other. I'm not afraid to tell you that when I started this 6.5 years ago, people looked at me. They were waiting for me to fail because I invalidated everything they did in their practices. However, now they're all my best friends. And you know, they literally wait for me to come to lunch so that I can help them. One person said, some people have Ronald Reagan's picture on their wall. We have your picture on our wall. And all I did was show him how he could divorce himself from Blue Cross. Pretty simple stuff. But I'm there to help. I so believe that this is what we must do. And this is where we must work together to create a threshold of need and to support our patients. We also have a hospitalist-based system. Now, again, this doesn't work in every community, but I'm, about 20 miles from Hoag Hospital, where we're building our first hospital-based system. We have a company called Real Docs, and think about it. In fact, I'll share this op-ed with you if anybody's interested. It's been actually, medical schools have asked to publish it because I talk about the patient-doctor relationship and what we, as doctors, have done to that relationship. Think about it. Most of our offices have a piece of glass between us and the patients. When the patient calls, there's not a friendly voice, there's a voicemail, and there's someone to protect you. God forbid you should talk to your patient. When the patient isn't too sick, we send them to the nurse practitioner. We don't even walk in to say hello. And when they're really sick, we send them to the hospitalist. And half the time, we don't even know they've been admitted to the hospital if someone doesn't alert us. Now, if that isn't disgusting. So we need to reintegrate this system and get back to our patients. We need to offer the heart, the hand. We need to touch our patients again and be in touch with their needs. That is what we do. That's why we went to school. So our hospitalist program, at a time when a patient is in greatest need, they can hire a hospitalist who will work with the primary care physician, or it can be the primary care physician. There are many students coming out of residency who are eager to become entrepreneurs. In fact, I had a group come to me the other day and say, you know what? We need to do something because we don't want to be commoditized. Can you help us? And I thought, ooh, that's pretty sophisticated. That's a pretty sophisticated way to think. Good for you. And indeed, what we're hoping to do is take residents right out of residency, the best of the best, and facilitate a hospitalist-based system where they don't see the patient once in the morning for 2 minutes and hire 25 different consultants to see the patient. No. They see the patient 2 and 3 and 4 times a day, whatever is necessary. They talk to the family. They talk to the primary care physician. They get the data so that the tests aren't redundant. Am I making some sense? Yep. And hospitals love it. In fact, if you're, there's been some animosity with some of our hospital partners, but in fact, they need to be our best friends. I'm very fortunate. My hospital is my partner. In fact, they called me the other day, and they said, Marcy, business is down. We're having a problem with our outpatient business. Do you know what's happening? Is the competition different out there? Are we doing something wrong? And I said, no, I think it's deductible time and yada, yada, yada. But I made some calls, and everybody's business was a little bit down, but I gave them a recommendation. I said, when patients walk into your waiting room, they really don't want to see a $2,500 MRI because that's not what it costs and that's not honest. So could you post your retail prices for once, please? And so they did. They did. Hello, they did. And they sent them out to the doctors. CT, $250. Mammogram, $90, including the reading. Now you tell me what woman cannot afford $90. And in October, breast cancer month, I think it's free. Chest x-ray, $75. Affordable. Absolutely affordable. But not if you use your insurance. Insurance just makes it so much more expensive and laborious. There is an absolute marketplace for our patients. They need to know the cost of care. And to that end, and I am very politically active, I now am working with the city council and the mayor, who are all my patients, in the city of Long Beach, and we are going to make it a matter of law and licensure in the city of Long Beach that anyone who wants to practice medicine or do anything related to medical care must post their retail prices. A market! Yay! How easy! How easy. Doesn't cost anything. I mean, wasn't this the frustrating thing? There's so many frustrating things with that stupid healthcare bill, but among them was their talk about cost. Nobody knew what the cost was. It was all smoke and mirrors, right? But I think that our patients, and quite frankly, we need to be a lot more familiar with the real cost of care so that we can offer value back to our patients. What a concept. In my retainer, I collect my retainer. I don't bill insurance, but I do give the patient a super bill should they choose to bill their insurance. While it's technically not yet legal to utilize HSAs, you can make it work. Wink, wink. I'll show you how. So now you have the patient using their HSA, and so it's a tax-deductible expense to come and see you. How affordable is that now? It's a tax-deductible expense for them to get their $75 mammogram, et cetera, et cetera, et cetera, et cetera. So it really starts to work. HSAs are the best, among the best things that have happened, and indeed, we need to politically work to expand that marketplace. There are simple fee-for-service, which you heard about. Dr. Watson, I think you have a simple fee-for-service. It's what works for you. And again, it's about you and it's about your patients, because this is about that relationship. Insurance opportunities. We had a long discussion today about what insurance really is. It is quite fascinating, isn't it, that we have lived in this marketplace where insurance has been so mal-defined. It is an actuarial bet. You cannot insure a doctor's visit. You just can't. Doctor's visits are benefits that people might buy. And as they're talking about the cost of health care going up, I wonder, do they include the cost of a good mattress? The cost of a good pair of shoes? That's health care, right? A haircut? Soap? I mean, where do we stop? We can define it as whatever we want.